I'll be talking about our study evaluating AI-based technology called computer-aided detection for chest X-ray interpretation for TB diagnosis in children. So we know that the diagnosis of TB is difficult in children and that most children with TB are never diagnosed. Chest X-ray does play a critical role to support TB diagnosis, but is really not easy to interpret in children. Also, countries with the highest TB prevalence often have the lowest availability of expert chest X-ray readers, such as radiologists. There has been development of this new AI-based technology called computer-aided detection, or CAD, which can support chest X-ray interpretation for TB in adults, but is not currently recommended for children. In 2021, WHO performed an independent evaluation of CAD and released this recommendation, endorsing the use of CAD for chest X-ray interpretation for pulmonary TB, but only in individuals aged 15 years and older. Since this recommendation, there's been an explosion of the use of this technology, with thousands of these CAD units being used worldwide in many different countries. In MSF, we've been using CAD since 2022, and currently we have implemented CAD in 5 different projects, primarily for TB screening. We're using it for screening in the community to support human readers, such as active case finding, but also using it for facility-based screening, such as in hospitals and clinics. So to give you a quick demonstration of this technology, we have your digital chest X-ray, and CAD can be used with any machine that produces digital images. This image is analyzed by CAD. It gives you, the output comes in less than a minute, and it gives you a color heat map, but more importantly, a CAD score from 0 to 1. To interpret this CAD score, it's necessary to identify or select a threshold, for example, 0.5, above which patients will be referred for confirmatory testing. So in this case, with a very high CAD score, sputum was collected from the patient, they were referred for confirmatory testing, and TB was confirmed. So why is CAD not currently recommended for use in children? The current CAD models are mostly trained on adult chest X-ray data sets, and there's a lack of quality pediatric data sets. The chest X-ray appearance of TB is quite different in children compared to adults. There's 2 examples on the right side with classic appearances of TB on chest X-ray in an adult and in a child. And you can see it's quite different in these 2 X-rays. So a CAD product that's been trained to detect TB in adults may not perform well in children. In addition, there's been a lack of studies assessing CAD performance in children. So to address this gap, we designed a study to evaluate the performance of CAD in children as part of the TB ALGO-PED study. There were 4 sites involved: Guinea, Niger, Nigeria, and Uganda, and the study cohort included children under 10 years with symptoms of TB, an available chest X-ray, and valid CAD scores. For the chest X-ray, we only used the frontal chest X-ray in a digital format. This could be DICOM format, which is the best diagnostic quality, a JPEG format, or in sites that are still using the old film and chemical processing, we took a photo of a hard copy film. For the CAD, we used a product called QXR, and we used the specific version which was trained and optimized for pediatric TB. As the reference standard, we used expert radiologist interpretation, which was a consensus of 3 external independent readings. Some of the characteristics of the 665 children included in the study: you can see the median age is 1.5, so it's quite a young cohort. 9% were living with HIV, and over 3/4 were living with SAM. 25% were diagnosed with TB, but you can see that only 13, so about 2% of the entire cohort, had laboratory-confirmed TB. And this is consistent with what we've heard with in terms of the low rates of lab-confirmed TB in children. So to assess the CAD performance, we generated these receiver operating characteristic curves, or ROC curves, which plots the true positive rate or sensitivity on the vertical axis and the false positive rate on the horizontal axis. And we plot these values for every single possible threshold to generate this curve. For example, at a threshold of 0.655, the sensitivity was 86% and the specificity was 53%. Then we measure the area under the curve, which gives you a value between 0 and 1. In general, an AUC above 0.8 is considered clinically useful. So overall, for our entire study cohort, the AUC was calculated at 0.76. So the CAD is showing fair performance for pediatric TB. It's not good, it's not bad, it's somewhere in the middle. This is the CAD performance broken down by the 4 country sites. We can see the ROC curves on the left and the AUC values in the table. There's a decent range here from 0.68 to 0.87. However, it's difficult to make comparisons between these countries because there was quite a difference in the population characteristics and also in the image format that was used as well. And you can see that in the right-hand column. However, in general, the sites that had the better image quality, Nigeria and Uganda, showed better performance with AUCs reaching 0.8 or above. So discuss some of the challenges involved with this specific technology. Image quality. We have seen that image quality affects the CAD scores, but this also affects human interpretation as well. And there are 2 aspects of quality. One is the image format, and there can also be technical factors, such as the positioning of the patient. To illustrate this, there are 4 bacteriologically confirmed TB cases that I'm showing below. All of these show chest x-rays that are suggestive of pulmonary TB. So they all should have high CAD scores. However, you can see there's a huge range in the CAD scores that are produced, from 0.88 all the way to 0.09. But if you notice the 2 chest x-rays on the right, these were photos of hard copy films, and the quality is not very good. And I do believe that the quality of these images is at least one of the reasons why the CAD scores are so low. 2, lymph nodes. CAD has difficulty detecting enlarged lymph nodes. This is probably the most challenging thing for human readers as well. The 2 examples on the right, these are both confirmed TB cases, and both demonstrate quite significant intrathoracic lymphadenopathy, as illustrated by the red arrow. These both should have given high CAD scores, but you can see the CAD scores are below 0.2. So the CAD is not picking up these lymph nodes. The lateral chest x-ray. Most CAD products do not accept the lateral view, but we know when we're reading chest x-rays that the lateral view is quite important, particularly for pediatric TB, and is currently recommended by WHO. The imperfect reference standards, both to train and evaluate our CAD models. We are using the radiologic reference standards, so expert readers. However, we know that human readers are imperfect, and there's quite a bit of inter-reader variability. But the low rates of lab-confirmed TB is a barrier to using a more robust reference standard, such as bacteriologic confirmation. And finally, the interpretation of CAD results in children. How do we use the CAD score to guide management in children? In adults, we use the CAD results to refer for confirmatory testing. But the lab testing is likely to be negative in children. So what do we do with this CAD score? How do we interpret it? So in conclusion, CAD is not yet ready for clinical use for TB in children, but there are promising results. And there's no doubt that CAD models will continue to improve with increasing access to pediatric chest x-ray datasets, which are currently being developed. The challenges for CAD are similar to the challenges for human readers in identifying TB on chest x-ray in children, detecting lymph nodes, accounting for image quality, interpreting the lateral view. And these challenges need to be addressed in order to generate a pediatric CAD model that is clinically useful. So overall, with improvements, CAD could have a significant role to increase TB diagnosis in children, to support the low expertise of readers and address some of the challenges of chest X-ray interpretation in children. Thank you, and I just want to thank the study team at TB AlgoPed and also the tactic team for all your hard work and dedication. Thanks.